Well, good day, everybody. This is Chris with the Ancient Scholar. Welcome back. And in this particular video, I'm going to talk about the two primary types or two primary categories of pulmonary pathology that you are commonly going to encounter and have to deal with when it comes to mechanical ventilation. And that is obstructive and restrictive pulmonary pathology. So when we talk about obstructive and restrictive diseases, think of obstructive diseases as diseases or pathologies that obstruct airflow through the pipes. All right, so this is an obstruction of airflow through the pipes. Think of things like bronchospasm. All right, think of things like secretions accumulating in the tube, or maybe the suction catheter is left in the endotracheal tube and it is obstructing the flow of air. A common cause of obstructive pathology, not really pathology, this is a more mechanical, but it's still a common cause of obstruction, is kinking of the tube of the equipment that obstructs airflow. Some pathophysiological causes of airflow obstruction are going to be things like, I mentioned, bronchospasm, bronchoconstriction, so asthma, chronic bronchitis, emphysema, bronchiectasis, cystic fibrosis, reactive airway disease. This airflow obstruction can happen with anaphylaxis and anaphylactoid reactions as well. And obstructive pathologies are going to present with an increase in the airway resistance. This is sometimes called RAW, R-A-W, that is airway resistance. Resistance is how much pressure it takes to drive a certain volume of gas into the airways in a certain period of time. And so airway resistance is commonly measured in centimeters of water per liter per second. In lungs where the airway resistance is very low and air can flow easily into and, of course, out of the pulmonary system, you're looking at an airway resistance of somewhere in the neighborhood of 10 centimeters of water per liter per second or less. So some people will say between 8 and 10. If you're less than about 10, your airway resistance is more or less normal. And then as you move above 10, from 10 to about 20 to 25, you are getting into an elevated airway resistance, or where you are having some sort of obstructive pathology, and then airway resistance that is greater than 25 is generally going to be quite concerning for substantial airflow resistance. What does this look like? So clinically, this is going to, the patient is going to have signs and symptoms of airflow obstruction. If it is their underlying pathology, you are going to listen to lungs, you may hear wheezing. When you monitor capnography, which you should be on any ventilated patients, you are going to see a prolonged expiratory phase and that classic shark fin pattern that develops. And there are also some things that you should note on the ventilator as well. So what I'm going to do is I'm going to initiate mechanical ventilation here. And one of the important pieces of information that you can gather from the ventilator is the flow time scalar waveform. Why is the flow time scalar waveform so important when it comes to identifying obstructive pathology? Well, it's important because airflow obstruction is the primary sequelae that we see in the setting of airflow obstruction. And so when we look at this, this flow time scalar here, you see the inspiratory and expiratory phase. So remember, an entire breath is inspiratory and expiratory. So you see, you inhale, and at the end of inspiration, the airflow kind of goes to baseline, to 0. Let's silence that for a little bit. Actually, let me just do this. I'm just going to turn our minute ventilation alarm setting way down so that doesn't keep happening. So what you're going to see is you're going to see this little pause, and then you're going to see the exhalation or the expiratory phase. And one of the things that commonly occurs in airway obstruction where the resistance is increased is it's going to take longer to exhale, because remember, exhalation is a passive process, and you're having to drive gas out of the body passively through airways that are obstructed. And so the classic thing that's going to happen is you will actually have the inspiratory phase begin before exhalation ends. And so what's going to happen is you are going to see a waveform that looks a lot like this here, right? So this is a square waveform. So this is a volume control ventilation as opposed to pressure control. But you inhale, you exhale, and then you're exhaling. You have this prolonged inspiratory phase, and then inspiration or inhalation begins before this returns to baseline. So remember, below baseline is expiratory flow, and so what's happening is the expiratory flow rate is decreasing, and this should come back up to baseline where there's no more flow, no more air flowing out of the lungs. But what happens is the next cycle begins before the patient's airflow goes back to 0, and that suggests that there is still air left in the lungs. And so this is classically what you see, is you see a breath occurring prior to the cessation of expiratory flow. So I'm going to try to demonstrate that in real time here. So what I'm going to do is I'm going to increase the respiratory rate here. That is going to make it more likely to occur. All right. And then what I'm going to do is, there you go. So you saw here, and here, you saw that inspiration began prior to the end of expiration. So let me see if I can do that again. There we go. See that there? And you see how you have these inspiratory breaths occurring prior to the end of exhalation. That is classically what you're going to see in severe states of obstructive pathology. The other thing that you want to do is go into your monitoring here, and in your monitoring, the ventilator is actually going to calculate the airway resistance. All right, so we talked about the mean airway pressure yesterday, but what we're going to do is we're going to go into some of these additional options here, and you can see that you've got your inspiratory and expiratory flow. But if I go down here into my third option under monitoring, you're going to see this up here on the upper left, the capital R insp. This is actually the airway resistance. This is the resistance inspiratory. And you can see it says 13 centimeters of water per liter per second. All right, so that is actually a little elevated, right? The airway resistance is a little elevated. And what I'm going to do is I am going to pinch the tube, the endotracheal tube, a little bit to artificially increase the resistance. And let's see what happens. You can see the airway resistance has gone up substantially, right? Now, if you were to see this occur suddenly like that, where it goes from 13 to over 100 suddenly, there are things you need to think about, like a kinked endotracheal tube, or perhaps a pneumothorax that has become a tension pneumothorax. Oftentimes, people will tell you that if somebody develops a tension pneumothorax on a ventilator, you're going to see a marked increase in the peak inspiratory pressure. But remember, this ventilator is pressure controlled, so there is going to be a pressure control regardless of the mode you select. And so you're really not going to see that. It's going to tell you that, you know, it's hitting its peak pressure, but you're not going to have pressures that are going to exceed the limitations that you set. But you can certainly see a marked increase in the airway resistance. So the monitoring your airway resistance and monitoring the flow time scaler are going to be two things that you can do with the ventilator that can detect the presence of increased airway resistance. And of course, you're looking at trends, and then you're also taking what you see, the lung mechanics that you see on the ventilator, and you are also ensuring that comports with the clinical examination of the patient, lung sounds, underlying history and physical exam, etc. All right. So how do we deal with airway obstruction? How do we manage it? Well, it depends on the cause, right? You've got to identify causes or likely causes. You know, if it's a kinked endotracheal tube, that's easy to deal with. If there are secretions in the artificial airway, right, suctioning it out. If the suction catheter is left in the tube, pulling the suction catheter back, right, those are things that can happen. If this is say a pneumothorax that has become a tension pneumothorax because we've initiated positive pressure ventilation, right, needle decompression may be required. If this is someone with bronchospasm, administering inhaled bronchodilators, and a little later on we'll talk about how to administer bronchodilators in line through the ventilator, right? So it's just a matter of finding the cause of the airflow obstruction and the increased airway resistance, and then addressing that cause. Now, there are some things you can do with the ventilator, such as decreasing the respiratory rate, right? So if you go in, you can decrease the respiratory rate, and that can allow, because at the end of the day, with the patient's pathology, what you're wanting to do is you're wanting to allow for a prolonged expiratory phase, and so you want to give the patient more time to exhale. So decreasing the rate can do that. And then another thing that's really important is the I to E ratio, specifically the I time and the E time. You actually want to give your patient longer E time, longer time to exhale, and you want to give them a prolonged expiratory phase. People with normal pulmonary pathology or normal pulmonary physiology are going to have an I to E ratio of around 1:2 to 1:4. You may need to extend this more to allow for that prolonged expiratory phase. So if we go back into the controls, what I'm going to do is I am going to adjust the I to E ratio, and I am going to give this patient, say, a 1:8, and you can see what that's done to the I time. The I time is now shortened. It's actually less than a second, 0.67 seconds. So for every cycle or every breath, 0.67 seconds is spent inhaling, whereas 5.33 seconds is spent exhaling, right? Now that's assuming that this patient is only receiving mandatory breaths, right? If this patient is spontaneously attempting to breathe and triggering the ventilator, the patient is also going to receive additional breaths if they're in assist control, like we are now, or they will receive pressure support if you have pressure support active if you are in an SIMV mode of ventilation. All right. So that is certainly something to think about. So those are some basic things that you can do to help a patient with a airflow obstruction or increased airway resistance pathology. In some cases, you may, because you have to decrease the respiratory rate and increase the expiratory time, you may end up hypoventilating the patient a little bit, and their carbon dioxide may actually increase because you're not blowing off as much CO2. And there is this concept of permissive hypercapnia, where what we do is we allow the patient's CO2 to rise a little bit to optimize their oxygenation and to allow for that prolonged expiratory phase. That, of course, needs to be done cautiously, and particularly in people with severe bronchospastic states like severe asthma attacks, status asthmaticus. You want to try to avoid placing an artificial airway in someone with status asthmaticus or someone with severe reactive airway disease, because they can be an absolute nightmare to manage on a ventilator. Because remember, exhalation is mainly passive, not only spontaneous breathing without an artificial airway, but certainly on a ventilator. And you now are providing positive pressure, and you have flipped that patient's underlying physiology 180 essentially, and the risk for air trapping, volu and barotrauma, and severe states of obstructive shock due to increased intrathoracic pressure is a primary concern when it comes to intubating or placing artificial airways in patients that are experiencing severe asthma attacks. So you want to avoid intubating those patients if at all possible, because the obstructive pathology can be fraught and life-threatening to manage on a ventilator. All right, everyone, hopefully that makes sense. In the next video, we'll talk a little bit about restrictive pathologies and lung compliance.